The topic of today's lecture is acute kidney injury in childhood. I'm Dr. Shenal, Thalgahagoda, consultant pediatric nephrologist at Pre-Renal. My email is there at the end of the slide for you to make any queries or make any suggestions. Let's start with the case history. So we have a previously healthy 3-year-old girl who was referred from the local hospital with a progressive reduction in urine output, which was noted to be less than 0.5 ml per kg per hour for the preceding 12 hours. This was associated with progressive edema, and she had also been extremely irritable. She had suffered from a diarrheal illness 3 days prior to the onset of symptoms. On examination, she was found to be ill and irritable with generalized edema, and she was also extremely pale. Her vital parameters were as follows. She had a pulse rate of 120 per minute with a good volume pulse. Blood pressure was elevated significantly at 130/90 millimeters mercury. Her saturation was maintained on air, and she was also noted to have bilateral pleural effusions. Moving on to the investigations of this child, a full blood count revealed a very significant anemia of 6.3 grams per deciliter. White count was basically unrevealing. Platelets were also significantly low. CRP was acceptable. Further investigations revealed a very high blood urea of 14.2 millimoles per liter. The creatinine was also significantly elevated. Sodium was normal, potassium was elevated, corrected calcium was marginally low, and the phosphate was marginally elevated. She also had a significant acidosis with a pH of 7.3 and a bicarbonate of 15 millimoles per liter, indicating a metabolic acidosis. So what is acute renal failure? So to start with a definition, acute renal failure is a sudden but potentially reversible inability of the kidney to maintain normal body chemistry and fluid balance. So it's sudden, which is why it's acute, and it is potentially reversible. And it is the inability of the kidney to maintain body chemistry in the form of electrolytes and also acid-base status, and as also it denotes the inability of the body to maintain an adequate fluid balance. So according to the previous slides, the case history that we discussed, this patient is in acute renal failure. And usually, acute renal failure is accompanied by changes in the urine output in the form of anuria, which is basically the absence of urine output, and oliguria, which denotes the passage of a reduced amount of urine, which volume is insufficient to maintain normal homeostasis. So even though the reduction in urine volume is to the degree that it does not clear the excretion of byproducts, as well as it is not sufficient to maintain acid-base homeostasis and body biochemistry. This oliguria is defined as urine output of less than 0.5 milliliters per kg per hour for children, and in neonates it is defined as urine output less than 1 ml per kg per hour. So how do you classify pediatric or childhood acute renal failure? One of the classifications used is the pediatric rifle criteria, or P-rifle criteria. Remember, there are other classifications also in use, but we tend to use this P-rifle criteria in our unit. So this P-rifle criteria has basically 5 entities denoted by risk, injury, failure, loss, and end stage. And you would note that each entity is defined by a decrease in estimated creatinine clearance or the renal function, or by a reduction in urine output. So accordingly, peripheral risk is a decrease in the estimated creatinine clearance by 25%, or a reduction in urine output or urine output of less than 0.5 ml per kg power going on for 8 hours. Injury is when the creatinine clearance decreases 50%, or there's a 50% reduction in estimated creatinine clearance, or the urine output has been less than 0.5 ml per kg power going on for 16 hours. Failure is when the estimated creatinine clearance or the estimated GFR is decreased by 75%, or the estimated creatinine clearance is less than 35 ml per minute per 1.73 meters squared. Or failure is also defined as a urine output of less than 0.3 ml per kg power going on for 24 hours, or if the patient has been anuric for 12 hours. So basically, as you would note that risk, injury and failure, when you move down the criteria, the severity of the acute renal failure obviously has increased, and a loss of renal function is defined as the persistence of failure going on for more than 4 weeks. So if this failure persists for more than 4 weeks, that is defined as loss, and the chances of recovery then become remote, and end stage is when the failure criterion persists for 3 months. Basically, that denotes that there is no chance of recovery from that point onwards, so that you need to manage a patient as chronic renal failure. So you have 2 sets of criteria defined by the GFR and defined by the urine output. So you need to, if one is in risk and one is in injury, you need to take the more severe one as the criterion to define the stage of acute renal failure. So if your creatinine clearance criteria fall into risk, but your urine output criteria fall into injury, you need to consider that patient as having injury. So what are the causes of acute renal failure, or the etiology of acute renal failure? Now, traditionally, acute renal failure has been, the etiology of acute renal failure rather, has been divided into pre-renal, intrinsic renal and post-renal causes. So pre-renal, intrinsic renal and post-renal. So what is the pathogenesis of pre-renal acute renal failure? Now, pre-renal failure is when there is a reduced circulatory volume, and this reduced circulatory volume leads to inadequate perfusion of the kidneys, and thereby a reduction in glomerular filtration rate, or a reduction in the functioning of the kidneys, brought about by a reduced circulatory volume leading to reduced renal perfusion. Now, this leads to activation of the renin-angiotensin-aldosterone system, as well as secretion of antidiuretic hormone, and both these lead so antidiuretic renin-angiotensin-aldosterone system activation leads to salt and water retention, and ADH. So this leads to formation of a very concentrated urine with fluid retention to maintain the intravascular volume, and this also because there is sodium retention by the kidneys, it leads to a reduced urinary sodium excretion. So what are the examples of pre-renal acute renal failure? Severe dehydration would lead to a diminished circulatory volume, inadequate renal perfusion and reduced GFR. Hemorrhage, shock, sepsis, cardiac failure, and hypoalbuminemia. Now, in dehydration and hemorrhage, the intravascular volume there's a loss of intravascular volume. In patients with shock, obviously, again, the shock, the causes of shock can be multiple, but in patients with sepsis, the reduction in glomerular filtration rate is due to severe vasodilatation, and this leads to the reduction in effective circulatory volume. Cardiac failure, again, because the heart is not pumping, there is a reduction in effective circulatory volume and poor renal perfusion. Hypoalbuminemia, there is redistribution of fluid because the fluid is not kept in intravascular compartment because of the loss of oncotic pressure brought by the hypoalbuminemia. So fluid leaks out of the intravascular space, leading to diminished intravascular circulation, and that in turn leads to reduced renal perfusion. Now, the important thing to remember in pre-renal acute renal failure is that if you replenish the diminished circulation or the reduced circulatory volume, and you re-establish perfusion of the kidneys, the acute renal failure is reversible. So you can reverse this, and it is potentially reversible with correction of the diminished intravascular volume. But if this reduced renal perfusion is sustained, your kidney gets damaged, and this leads to intrinsic renal failure. And at that point, it is not reversible by replenishing the fluid. You need to wait till the kidneys recover on their own. The renal, an element of renal damage has set in at that point. Now, this algorithm basically describes the pathogenesis of pre-renal acute renal failure. So when there is renal hypoperfusion brought about by reduced circulatory volume, you get neurohormonal activation in the form of renin-angiotensin-aldosterone system, which leads to sodium and water retention as well as vasoconstriction. Sympathetic nervous system increases the cardiac output and increases the vascular tone and tries to perfuse the kidneys. Antidiuretic hormone reduces diuresis and again leads to fluid retention, and prostaglandins also cause fluid lead to reduction in the peripheral circulation through vasoconstriction and improved intravascular and improved renal perfusion. So, what are the systemic effects brought about by these neurohormonal activation? By this neurohormonal activation, rather. So you get vasoconstriction, which causes there's a peripheral vasoconstriction. So you increase the effective volume and increase the renal perfusion thereby. You maintain the blood pressure again through the vasoconstriction as well as the salt and water retention, and this in turn leads to renal perfusion. And what are the renal effects that this neurohormonal activation leads to? You get efferent arteriolar vasoconstriction, afferent arteriolar vasodilatation. So your efferent arteriole constricts, afferent arteriole dilates, and you improve the glomerular filtration. You improve the fluid, the amount of blood flowing into the glomerulus, and thereby you maintain the glomerular capillary pressure and perfusion. And also the kidney is involved obviously in the salt and water retention. So this effectively restores, or may restore renal perfusion, and if the renal perfusion is restored on time, as I mentioned earlier, the acute renal failure is reversible and the renal function returns to normal. But if there is prolonged and severe renal ischemia, the pathophysiological processes depicted here will lead to acute tubular necrosis or tubular injury. and these basically this basically means that the kidney has undergone some amount of renal damage, and when it comes to that point, it is not reversible by replenishing the circulatory volume. So you need to wait till those kidneys recover. So acute tubular necrosis, as depicted here, in acute tubular necrosis, there is cytoskeletal deterioration, there is cytoskeletal degeneration, there is loss of the cellular polarity, and the tubules don't function with the normal absorptive and secretory processes, and the tubular cells undergo cell death. So let's move on to the pathogenesis of intrinsic renal failure. Now, intrinsic renal failure is where the renal failure is due to renal parenchymal damage. We discussed in the previous slides how pre-renal failure, if sustained, will lead to renal damage in the form of acute tubular necrosis, and this would in turn cause renal parenchymal damage, which is intrinsic renal failure. What are the other methods of getting intrinsic renal failure? It can be glomerular damage in the glomerular nephritis, like acute glomerular nephritis, post-streptococcal acute glomerular nephritis, which we will be discussing in a subsequent lecture. Hemolytic uremic syndrome is another cause of glomerular cause of acute renal failure. Henoch-Schönlein purpura and systemic lupus erythematosus nephritis due to these conditions also can lead to acute renal failure. Ischemic, we've already discussed, acute tubular necrosis due to prolonged pre-renal failure. Nephrotoxic intrinsic renal failure can be due to drugs, can be due to tumor-lysis syndrome, which is where when you treat certain malignancies, there's a release of substances that are nephrotoxic. There can be when there's massive hemolysis or massive breakdown of the red cells. This leads to a release of hemoglobin, and hemoglobin is toxic to the kidneys, which leads to a hemoglobin, what is called a hemoglobin nephropathy. That is another form of nephrotoxic intrinsic renal failure. And muscle breakdown, say severe exercise, can lead to release of myoglobin from the muscles, and myoglobin, just as hemoglobin is nephrotoxic, myoglobin also is nephrotoxic, and it leads to a myoglobin nephropathy, which is again intrinsic renal failure. And if there is very severe infection of the kidneys, fulminant or fulminant pyelonephritis, this would again lead to intrinsic renal failure. And acute tubular interstitial nephritis is a condition where there is inflammation of the renal interstitium, the tubule area or the interstitium, not the glomeruli. And these patients, these patients usually present with what is known as polyuric acute renal failure. So their urine output is not diminished; in fact, it is accentuated, and you have an increased urine output of polyuria. So, but your renal functions are deteriorated. So, let's just touch on the pathogenesis of post-renal failure. Post-renal failure is where your renal function is acutely diminished due to entities or due to an obstruction distal to the kidneys. So pre-renal is before the kidneys. Intrinsic renal is where the problem is intrinsically in the kidneys. Post-renal is where the problem is distal to the kidneys in the collecting systems. So basically, these are disorders of any disorder causing urinary tract obstruction. So in neonates, the common entity is posterior to valves, where there is a valvular obstruction at the base of the bladder, which leads to a reduction in urine output. It can be severe enough to cause anuria as well. There can be patients can have bilateral bilateral pelviureteric junctional obstruction, or where the renal pelvis meets the upper part of the ureter. There can be obstruction there. So if it is bilateral, the patient will present with acute renal failure. So this PUJ obstruction may even in older children, the common cause of this PUJ obstruction, it's not a common cause, it's a very rare entity, but you can have stones or urinary calculi obstructing both PU junctions, or you can have calculi obstructing the bladder. Large calculi can obstruct the bladder, and if it is prolonged, the obstruction is prolonged, that can lead to post-renal acute renal failure. The obstruction can also be in the form of tumor, and it can be a functional obstruction when your bladder is not contracting properly, and it basically leads to distension, backflow of urine, and this obstruction, if prolonged, can even lead to acute renal failure. So the important thing about post-renal acute renal failure is that relief of obstruction will lead to recovery of the kidneys. So as you would note, a thorough history will suffice to denote what the cause or the etiology of your acute renal failure. So to continue with the clinical features, remember, you need to, from your history, you need to assess the sufficiency of your patient's urine output, or you need to assess how much urine the patient is passing. Now remember, most patients will be oliguric or anuric, or they won't pass you, they will not have passed urine for a significant period of time. But as I mentioned, patients with tubular interstitial nephritis may even be polyuric. So it's a bit difficult in these patients to diagnose acute renal failure. So in your examination, assessment of volume status is of utmost importance. And remember, your management, the initial management, depends on your assessment of volume status. So if the patient is overtly dehydrated, he has poor perfusion, tachycardia, then you need to think of pre-renal acute renal failure. So these patients, what you need to do is just give some fluid, and with replenishment of the intravascular volume, the renal failure will resolve. If the patient is edematous, hypertensive, has evidence of volume overload as denoted by a gallop rhythm or basal crepitations in the lungs, you need to think about intrinsic renal failure. And in these patients, who are edematous and hypertensive, they are volume overloaded. You give fluid to these patients, you will kill them. So that's why I say it's extremely important to get the assessment of volume status right at the onset. So you go and give fluid to these people, you're going to basically kill them. If there are frank masses or a palpable bladder, you need to think of post-renal acute renal. So I've denoted here the differences you'd obtain in patients with the differences in the investigations that you would obtain in patients with pre-renal failure and in patients with intrinsic renal failure. So remember, in pre-renal failure, due to the action of aldosterone and due to the action of the renin-aldosterone and renin-angiotensin-aldosterone axis, you're passing a concentrated urine that is low in sodium, because there's salt and water retention, and due to the action of antidiuretic hormone, you're passing a concentrated urine, right? So that's in pre-renal failure. So in these patients, because of the concentrated urine, pre-renal failure will have a high specific gravity. In patients with intrinsic renal failure, the because there is no concentration of urine due to the damaged kidneys, their specific gravity will be low. Your urinary osmolality, again, because the urine is concentrated, your urinary osmolality will be high in pre-renal failure because it's a concentrated urine. In intrinsic renal failure, it will be relatively lower, less than 350 milliosmoles per liter. I said, due to the action of aldosterone, there is salt and water retention. So in pre-renal failure, because of the renin-angiotensin-aldosterone axis, your urinary sodium will be very low. So it will be less than 20 millimoles per liter. And in intrinsic renal failure, because of the damage to the tubule, there will be leakage of sodium, and your urinary sodium will be higher than 40 millimoles per liter. Now, we do calculate the fractional excretion of sodium, which basically gives you a more accurate idea as to whether the kidney is conserving sodium or not. So I'll show you how to calculate it in subsequent slide. So the fractional excretion in pre-renal of sodium is basically less than 1 in pre-renal failure, and it is more than 2 in intrinsic renal failure. The figures are slightly different, but significantly different for neonates. So how do you calculate the fractional excretion of sodium? So the fractional excretion of sodium is the urinary sodium divided by the plasma sodium into the plasma creatinine divided by the urinary creatinine. So there's a switch of the sodium. The sodium urine is urine is on top, plasma is below, creatinine, the plasma is on top, urine is below. So rest of the investigations, you're also going to need to do an ultrasound scan of the kidneys to see whether there is any underlying structural anomaly which has basically sent the patient into acute renal failure. And also it's important to detect the cause of post-renal failure. And very often in patients with intrinsic acute renal failure, you need to do a renal biopsy to find out the exact cause. And this is more so in the patients with glomerular causes of acute renal failure, and also the tubulointerstitial causes. So let's move on to management. Obviously you need to assess your airway, breathing and circulation. Airway and breathing should be alright, but the circulation might be deranged, and you need to address that. And as I mentioned in a previous slide, determination of volume status is of utmost importance. You need to assess whether the patient is dehydrated. If he's dehydrated, he needs fluid. If he's euvolemic, he doesn't need fluid. And if he's intravascularly volume overloaded, you need to restrict fluid. So if you get this wrong and you give fluid to a volume overloaded patient, the consequences can be disastrous. So you need to send out investigations that we've discussed, and you need to catheterize the patient more often than not, because you need to stringently monitor the urine output. And monitoring of the urine output is essential for the subsequent management of these patients. So how do you manage the patient according to the hydration status? So if the patient is dehydrated and he has evidence of acute renal failure, you need to correct the circulation. So you can give a bolus of, if the patient is in shock, you can give a bolus of normal saline, 10 ml per kg, just to see, and you can repeat it you can repeat it until the acute renal failure, until the shock has get corrected. And if the patient is in severe dehydration, you need to correct your dehydration quite rapidly. Probably the WHO method is more relevant here because the patient is in acute renal failure, and you need to replenish the diminished perfusion of the kidneys quite early. If the patient is euvolemic and you're not really sure whether he is slightly under, so these patients will be normotensive. They won't show overt dehydration, and there obviously won't be edema. in these patients you can give just a bolus of normal saline 10 ml per kg over about 30 minutes, and you can follow it up with a small dose of furosemide just to see whether the patient improves, and just to see whether there is a hypoperfusion there is an element of hypoperfusion of the kidneys. Now, if the patient is volume overloaded, edematous, hypertensive, then you can try with a high dose of furosemide. So what you can give 2 to 4 milligrams per kg. Some units even go up to 6 milligrams per kg. So you give a high dose and see whether the patient improves. If it doesn't improve, don't give any further doses of furosemide. If the patient has is known to have nephrotic syndrome and is found to be hypovolemic and in pre-renal failure due to nephrotic syndrome, you need to consider giving human albumin or cryoporoplasma to these patients, because in nephrotic syndrome the hypoperfusion or the intravascular volume is depleted due to reduced albumin, and if you just give normal saline to these patients, it just go in and out of the intravascular volume, so you are not really replenishing your intravascular volume by using normal saline. You need to consider giving albumin to these patients. If the patient has evidence of hypotension and if the patient is hypertensive rather, you can use a low dose of dopamine to increase the renal perfusion. So dopamine at low doses, less than 5 mics per kg per minute, are thought to increase renal perfusion, and this can be helpful in patients who are hypotensive. Certainly you're not going to use dopamine in patients who are hypertensive. And also importantly, you need to treat the cause and remove the precipitants. Now, if there is sepsis, treat the sepsis. If there are nephrotoxic drugs on board, you need to stop them at once. If there are other toxins on board, you need to address those, or you need to get rid of them. And if the patient is hypovolemic, as we mentioned, you need to address that. And if the patient is having conditions like rapidly progressive glomerulonephritis or severe forms of nephritis, you need to treat those accordingly as well. Now, moving on to further management, you need to strictly monitor the input and output with a strict input-output chart. Now, if the patient is in acute renal failure, what we usually do is you maintain the input and output, and you chart it every 4 hours, so that you assess the patient very frequently. And what you would, the fluid, if the patient is oliguric or anuric, what the amount of fluid you would give, you assess the input output for 4 hours, and the amount of fluid you would give for the subsequent 4 hours or for the next 4 hours would be the previous 4 hours urine output or plus the insensible loss. So in the first 4 hours, if the patient has a urine output of 100 ml or say 50 ml, you need to, in subsequent 4 hours, you will give 50 ml plus the insensible loss for the 4 hours. So urine output plus insensible loss in the subsequent 4 hours. So as I mentioned, replace the urine output plus the insensible losses. Usually in acute renal failure, you don't do it every day. You do it every 4 hours, some maybe even every 2 hours, right? If the patient is in severe, is in volume overloaded state. If the patient is euvolumic, not hypertensive and not significantly volume overloaded, you need to replace 100% of the urine output plus the insensible loss. But if the patient is overloaded, has evidence of heart failure, like with a gallop rhythm, in these patients you don't replace full urine output. Even if there is a urine output, you don't replace the full urine output, you restrict it. You replace only 50% or 75% of the urine output. You're obviously going to need to remove the potassium, and that can be done through dialysis. Acidosis, as I mentioned, you need to treat urgently if the pH is below 7.15 or the bicarbonate is below 8, and the formula you use is 0.3 into base excess that is given on your blood gas analysis into into the body weight in kilograms. You divide so whatever figure you get, you divide it by 2 if you're doing a half correction, which is usually what we do. You do half correction and let the body take care of the rest. But you might need to repeat it if the acidosis is severe. Hypocalcemia is treated with calcium gluconate, especially if the patient is symptomatic. And hyponatremia, you would obviously need to restrict the fluids, which would anyway be done if the patient is oliguric. And symptomatic hyponatremia will require correction, or you need to correct it if the sodium is below 120 millimoles per liter. There again, the formula we've dealt with in our previous lecture. So other forms of management: if there is gastrointestinal bleeding due to the stress response, you can use H2 receptor blockers. If the patient is hypertensive, you can use calcium channel blockers. Remember, you do not use ACE inhibitors or angiotensin receptor blockers in patients in acute renal failure, because they worsen your GFR and they also cause hyperkalemia. So these patients are prone to hyperkalemia, so you can worsen the hyperkalemia and kill the patient by using ACE inhibitors. Hypertensive encephalopathy is treated with intravenous labetalol or hydralazine or sodium nitroprusside. We also use GTN or glyceryl trinitrate infusions. If the patient is anemic, a blood transfusion may be necessary if the HP is less than 8. So you need to also adhere to or attend to the patient's nutrition. So these patients, if the patients are hypertensive, you might need to restrict your sodium, but remember, if there is hyponatremia, this restriction should not happen. Potassium and phosphate will most often need to be restricted. Proteins, remember, children need proteins, so you need to give high quality proteins, and you need to give 1 gram per kilogram per day. You need to restrict the low quality proteins such as plant proteins, and restrict your proteins to high quality proteins. Caloric intake needs to be maintained, so you need to give adequate calories to prevent muscle breakdown and worsening of the uremia in these patients. When would you consider dialysis in patients with acute renal failure? Refractory hyperkalemia, so if your hyperkalemia is not getting corrected, if your acidosis is not getting corrected, if there is refractory hypertension, so you can't manage the hypertension, if the patient's fluid status cannot be managed, if there are severe uremic symptoms like the blood urea is causing a cardiomyopathy or pericarditis or uremic encephalopathy, all these things can occur because of the uremia. Or if your blood urea is above 40 millimoles per liter, that's a definite indication to start dialysis. And if there is prolonged anuria or oliguria, early dialysis is helpful. Deteriorating levels of consciousness would be multifactorial. It can be due to hyponatremia. Uremia would probably be the most common cause. So if there is a deteriorating level of consciousness, you need to dialyze the patient as well. What are the modes of dialysis? You can do acute peritoneal dialysis. You can do intermittent hemodialysis. Remember, intermittent hemodialysis requires the patient to have a normal blood pressure or elevated blood pressure. You can't do it if the patient is hypotensive. So if the patient is hypotensive, your usual option is what is called continuous renal replacement therapy, or CRRT. So what is the prognosis of acute renal failure? It obviously depends on the cause of acute renal failure. Patients with pre-renal failure have the best prognosis. Just replenish the fluid and they will come out of it. Hemolytic uremic syndrome, if it is diarrhea associated, has a good prognosis. Acute tubular necrosis, again, even with prolonged pre-renal failure, acute tubular necrosis can occur, and that again has has a reasonably good prognosis. Tubular interstitial nephritis has a relatively good prognosis as well. But patients with rapidly progressive glomerulonephritis or severe forms of glomerulonephritis, if there is bilateral renal vein thrombosis, cortical necrosis due to prolonged hypoperfusion of the kidneys, these have very, very poor prognosis, and the patients usually end up with chronic. So that's basically all I need to discuss regarding acute renal failure. You'll be wondering about the case history I gave at the beginning of the lecture. So all you need to do is go through the case history, try to identify the abnormalities brought about in the history and in the abnormal examination findings. Try to fit into which category of fluid status the patient falls into. Try to fit it into which category of etiology of acute renal failure the patient fits into, and also try to find out what the diagnosis of that particular patient is. And thereafter you need to go through the investigations and delineate the metabolic derangements that the patient has, and what you're going to find out, what you're going to do, and define what you're going to do about the metabolic derangements from what you have learned in the lecture. Thank you.